Okay, welcome and good afternoon. This is the third session of this series in healthcare reform. And my name is Tony Denuzzo. I direct the East Texas Geriatric Education Center Consortium. And I want to acknowledge our partnership that we have with several stakeholders, but including the East Texas AHEC, who provides us with lots of communication in our pretty large service area. This is the TGC is a HRSA funded grant that we have now for another 4 years. So we have a lot that we can do. This is our first year in this cycle, and we decided to do a series to explore the issues related to healthcare reform. And this is our third session. The first two provided the overview. It was the material, the information that you needed to move on to the sessions that would follow in terms of applying some of the things that we've been talking about. All these sessions, by the way, are recorded, and so if you ever want to take a look at them, again, we will have DVDs available for you. So this session kind of takes what we've been talking about and exploring in depth through interprofessional panels, a discussion about healthcare reform, as well as what we are doing for the care of older patients in terms of primary care and those standards that we try to uphold. And how will this possibly change with healthcare reform, and we're dealing with policy issues, things like that. Let me give you a... next month, on May 18th, we're going to have what may be like bringing it all together. Where is this all going? Where is it leading to? And so we're going to have the implications of healthcare reform. In addition, we're going to have a panel of older folks here from OLLI, the group that works on lifelong learning. And so we're going to have a panel there, and you're going to hear from them how they feel and their fears and concerns, some of the anxieties that are going on in terms of changes in healthcare that could be on the horizon. This is our agenda, and you should have handouts that you could follow along with any of this as well. We're going to start with Dr. Karen Sauter giving dilemmas in providing health care. This will be stories written by medical students about what they're dealing with rationing of health care. We'll have a short break, and then we're going to have a panel discussion up here with a very interdisciplinary group that we'll introduce and talk about. And we'll have panel discussion questions that are also in your handouts. And then we're going to have evaluations afterwards, which are very important so we can make changes if needed. And you could ask me any questions along the way, but I did want to do this kind of quickly so that we can get going with Karen's talk. These are the learning objectives as stated in all our forms, especially when it comes to continuing education. This is what we want to try and look at today. The first two will be related to Dr. Karen Sauter and addressing the dilemmas in healthcare. The next two are for the panel that will be talking about healthcare reform and primary care. We broadcast to 5 sites throughout East Texas. We have Lamar University in Beaumont, Stephen F. Austin in Nacogdoches, Baylor University in Waco, Victoria College in Victoria, and also Weatherford College in Decatur. All right? Okay. And we welcome them, and I haven't seen them on the screen yet, but hopefully we'll be able to. When they come up, it looks like Hollywood squares. It's great. You know, so I try to identify who they are, and it's a challenge, but we get it done. Okay, we do offer continuing education credits for medicine. All the forms should be in the back. If you are requesting CE credits for medicine, this relates to MD, DOs, nurse practitioners, and physician assistants. You can get 3 hours of credit, and they are free. The GEC pays for them. The main thing is sign in, fill out the forms completely, and then hand them to our assistant in the back, Kelly Prevo. All right. We also offer 2.75 hours for CNE for nursing credits. This is for RNs. LVNs will receive a certificate of attendance if they so request on their sign-in sheet. There is a separate sign-in sheet for C&E, okay? It's really important to fill out all the information if you are requesting C&E credits. I will have the disclosure now that the Planning Committee for C&E and Faculty Content Specialists of this activity disclose no relevant professional, personal, or financial relationships related to the planning or implementation of the C&E activity. And in fact, none of our speakers today, the panelists, have any commercial affiliations to disclose. Okay. We offer CE credits for physical therapy and occupational therapists. This is 3 contact hours. They are based on filling out the general evaluation form and the sign-in sheet. Okay. Dr. Karen Sauter is going to be talking about dilemmas in providing healthcare, lessons in decision making. She received her MD degree from Case Western Reserve, completed residency in internal medicine and fellowships in gastroenterology and nutrition. She's a professor currently in the Department of Internal Medicine, Gastroenterology, and a senior medical educator in the Office of Educational Development. I'd like to also add that Dr. Sauter, we've been working together on the standardized patient programs. It's a valuable tool for education that we're using at other sites and for our clinical training. It's a great area for education. She's as I said, medical director for standardized patient program, works with the SP staff to ensure that medical aspects of the SP cases and portrayals are accurate. She coordinates projects and research in the Standardized Patient Center. Areas of interest are, in addition to standardized patients, include teaching and evaluation of clinical skills and professional development. Many of you know Dr. Sauter, so I'm really glad that she's here to do this first part. Okay.
So I hope that you will find the next 45 minutes or so of discussion and reflection rewarding and enjoyable. I'm going to begin this discussion by laying some groundwork for you, and then we're going to have an open discussion. So I'm going to start, and Cheryl Viana is going to be here as a discussant. I'm also incredibly delighted that we are using student material for this discussion, and one of our medical students was able to attend today, so he will be participating, David Darrow, and I'll introduce him. And I am going to use the computer. So the objectives for this is to talk a little bit about some of the dilemmas in healthcare provision from the perspective of medical students, to look at some of the systems issues that have a potential to be modified with healthcare reform, and then finally to talk about some ways that we might address some of those issues in healthcare provision. I first want to recognize and thank the following students for their willingness to allow me to use some of their academic material for the purpose of this discussion. You'll see as I go through that I'm going to be using some things that the students actually turn in as part of their internal medicine requirement. But in reading these, they're incredibly rich, and I think the student's perspective is very valuable as we talk about issues of healthcare reform. So as I think about, and I'll just give you a quick background, as I think about the way we currently train in medical education and in healthcare education in general, we really look at the patient, and then we sort of think about the patient as a unit of a family, and then less so the family as part of a community, and less so the community as part of a society. So much of the focus that we currently have in our teaching of students is really focusing on an individual. And I think as I read through some of these and focus on some of the dilemmas that the students have recognized, that point will become a little bit more clear. Also in medical education, as I thought about the curriculum that we use, we're very, very strongly focused on the biomedical model of patient care. And as we work through, we start to introduce more issues related to the psychosocial aspects of patient care and how those two interweave. But we've been less successful or less focused as medical educators in talking about healthcare systems. And so what we're going to focus on, I think, is students situational learning a lot about healthcare systems and how this all kind of relates back to providing healthcare. If I'll ever be quoted on anything, this is sort of my motto: you can't teach experience. And so as much as I would like to be able to lay a lot of this stuff out for the students and say, here's the stuff that's going to drive you nuts, or here are the things that you're going to see that you're really going to struggle with, we can't. We have to let them happen. And so as part of this, I think, again, as I now will give you the background on this, you'll understand where these stories and concerns and issues and learning have come from. So in the Department of Internal Medicine, we have had a seminar series in place for several years called Challenges in Medicine. And the focus of that seminar series was for students to come in, and we would talk about issues related to truth-telling and informed consent and end-of-life decisions and many things that we all deal with regardless of the patient population that we deal with. And then we had this little event in September of 2008 which kind of changed the way we had to organize the clerkship, and our students got scattered, and so we initiated in 2008 a requirement for an essay rather than having a seminar series. And as our students have continued to be dispersed, we've continued these essays, partly because Dr. Carnap and I, who read these through, felt like the students, although they were only focusing on one topic, their reflections and their discussions were really rich. So the requirement is that they think about a patient experience that they have had. They define the topic that they find interesting in the list of topics. They read the literature related to whatever was stimulated about that patient, and then they reflect and comment on what they've learned. And so the essays that I've pulled for today were from the 9 students that I showed you at the very beginning. Again, the students that I want to thank. And with their permission, with their express permission, we'll be using samples from their essays to make some of the points that I think are worthwhile in discussing. So our first objective was to discuss dilemmas in healthcare provision from the perspective of medical students. One of the students opened his essay with this statement: "I never realized how broken and abused the healthcare system was until experiencing it for myself in the clerkships of the 3rd year." And I think this really drove home a point to me that when the students think about healthcare, and particularly in years 1 and 2, they're often thinking about it the same way that they think about it almost as a layperson. They haven't been in the system providing care to a patient. And when we push them into the 3rd year and they're doing healthcare, direct patient care 24/7, all of a sudden they start seeing some of the things that we've been teaching them in years 1 and 2 aren't quite as simplistic or easy to deal with as they had originally been suggested that they might be. So the first 2 essays I would like to read from, kind of as I was sort of theming these, and we'll summarize this at the end, I sort of called these caught in the middle. And so the first one is a story that reads as follows. Gentleman was brought to the hospital complaining of a nagging cough, some hemoptysis, shortness of breath, dyspnea on exertion, and tenderness of the 2nd, 3rd, and 4th rib. He had no significant past medical history other than a 30-pack-year history of smoking. But due to his lack of health coverage, he had not seen a primary care provider for over 10 years. During the past 8 months, he went to the nearest ER of a private hospital twice, only to be sent home with an antibiotic and muscle relaxant with no instructions for follow-up. He ended up coming to our institution a month later. He works as a clerk at a local fast food restaurant and doesn't have insurance. He was not offered health insurance from work and cannot afford to pay for health coverage, doesn't qualify for Medicaid or others because of his income as a clerk. The student goes on to tell us that this patient, very unfortunately, is diagnosed with metastatic adenocarcinoma of the lung. And then responds as he goes through this discussion: for the above-mentioned patient and other 46 million uninsured Americans, the health care is rationed mostly by affordability. Through my interaction with this patient, it seemed obvious that the expensiveness of healthcare services was the primary reason not for him to follow up with a primary care provider. This led to unchecked progression of cancer due to lack of proper treatment and uncontrolled hypertensive complications. If proper cost-effective care was available to the patient, his cancer could likely have been diagnosed at a much earlier stage and would have prolonged his life expectancy. Providing appropriate medical care to the masses while keeping cost in control will be one of the biggest challenges medical staff and us as a nation face in the 21st century. And then the student goes on to talk a little bit about some of the other issues, but I think that sort of gives you a global sense. The next one is a 61-year-old man who hasn't been to a primary care doctor in the last 10 years because of no health insurance coverage. The student says that the doctor that he was working with at the time agreed to see him. This was in a private practice setting at no expense. By the time the patient comes in, they document that he has a strong family history of diabetes. He has sensory changes of his lower extremities, laboratory studies which show changes in his urine, a very high fasting plasma glucose level, and a hemoglobin A1C of 8.7, which for those of you that aren't familiar with the lab cutoffs, that's quite high. He then goes on to talk about how, again, here's a patient with a disease, a progressive chronic disease, that if it's diagnosed early can be treated and the healthcare complications of this can be managed. But again, a patient who has had inadequate and no healthcare because he couldn't get into the system. Perhaps the solution in some part lies with individual physicians. When working with my ambulatory doctor, he would save free samples of medicine for my patients who could not afford them. He would also see patients who were unable to pay, such as this one. On a small scale, he was helping make the healthcare system more accessible and available. Despite whatever may occur at a government level, I've learned from this experience that with a little altruism, a physician can overcome some of the barriers. So I think the nice thing that I pulled from this is we see a problem, but we also see that there are some, even at an individual level, some potential things, and as we discuss, some solutions. I'm now going to ask David to come forward, and he's going to share parts of his essay with you. And this section is what I'm calling restricted access.
So my name is David Darrow. I'm a third-year medical student. My tale is sort of a tale that's becoming ubiquitous in the sort of medical community with the high incidence of diabetes, and one that I think if you haven't seen it already, you'll see very soon. So Mrs. R is a 43-year-old Hispanic female who presented with a lupus exacerbation and was found to have an estimated GFR of 14. She immigrated from Mexico 25 years ago with her 2 children to finally meet up with her husband, who was working in Galveston. She has worked cleaning houses in the neighborhood whenever her disease allows in order to help support the family and to supplement her husband's under-the-table job. She was only ever able to afford prednisone for treatment to prevent recurrence, and she takes every medication prescribed that she can afford religiously. She adheres to the strict recommended sodium intake. Through her work, she is constantly exercising and she avoids sun exposure. She is delightful in the hospital, even to medical students, and she is gracious even in the face of bad news. Essentially, she's the type of patient that makes medicine rewarding. The only thing that impedes her courageousness is that she's an undocumented immigrant. Her story and my experience with her reminded me of how little I do and how powerless I am. Rationing healthcare is a hot-button topic today, especially since even middle-class citizens struggle to pay for care and afford health insurance. With an economy that is continuing to recover and a media that is built to instill fear, figuring out how to prioritize healthcare is a challenge for physicians and even more so for patients. The debate really boils down to what is considered to be necessary care and how society or the individual is to pay for that care. Necessary care has a multitude of interpretations, but the derivation has a simple premise. What is the most suffering that one is willing to allow? In practice, the answer to this question can be very complicated. There could be stipulations on the cause of suffering, the type of patient, second and third order decisions that may have been made previously also come to play a role. Along the same train of thought, there are practical implementations of what many would consider basic care, such as occasional access to physician or mid-level providers, basic screening or diagnostic laboratory examination, or immunizations. In our country and state today, the situation is much more complex than a simple interplay between humanitarianism and fiscal responsibility. For those that have been taxed, they are rewarded with a confusing healthcare regimen at 65 years of age, covering on average the last 12 years of their life. For those citizens with extreme disability, the options are even more confusing and vary widely by state. In the case of children, though they usually have basic health care coverage in most states through S-CHIP, support for the program is dwindling. For the average adult, there is no coverage on whether one is a citizen or an undocumented immigrant. Healthcare legislation until recently has set a precedent of encouraging government-subsidized services for the young and the old, leaving those in the middle to pay for their own care using their insurance or out-of-pocket expenses. The Emergency Medical Treatment and Active Labor Act, EMTALA, was set up to prevent payment ability from being a deciding factor in emergency situations. Through EMTALA, a federally funded emergency department cannot turn away a patient or transfer a patient until they are medically stable. Emergency Medicaid and EMTALA compose the thin safety net for adults in the United States. Requiring emergent situations to receive care for those that absolutely cannot afford or cannot find care has driven the emergency department to become the kind of technological machine that it is craved to become. As a result, the disease states that arrive are more severe and requiring enormous resources to prevent impending death. Unfunded patients quickly learn that they may only receive care when their situation is dire, driving the overall cost of healthcare incessantly higher. For my patient, Mrs. R, emergency dialysis will be her inevitable future. She is motivated to serve her family, but her ability to do so will be hampered by an unending crisis of dysregulation and nitrogenous fog. Still, she is capable of understanding the dysfunctional bureaucracy that resides between our compressed consciences. Her story is tragic, and it is not uncommon. Mrs. R is only one of the many patients that is lost in the confusion of healthcare rationing and resultant hospital policy. This is not an issue with an easy answer, but Mrs. R's case makes it clear that the solution that has emerged is simply not working. Mrs. R has certainly made an impression on me. She has reminded me of the disparities that still exist in medicine today. She has personally brought to light a severe dysfunction in our healthcare system, and I hope to make a difference where I can by giving her and similar stories a voice.
Thank you for bravely speaking the student's voice today. Following the similar tenor of the discussion that David just presented, another student wrote about a 47-year-old patient, also an undocumented immigrant, who has to go to the emergency room every 3 to 4 days for emergency dialysis. And if you don't know, in the United States, dialysis, all patients who require chronic renal dialysis receive coverage from Medicare for dialysis unless they're an undocumented immigrant, at which time they cannot receive that coverage. And the irony, as many students, and remember we've been getting essays over the last several years, a lot of students have brought up this issue, and it's not the issue of the patient group per se that I want to talk about, but it's the irony of how we're rationing health care. So I think that from this second essay, the part that's really worth listening to is his discussion of the literature. In addition to the ethical concerns created by this situation, there's a question of whether this policy is an efficient allocation of scarce resources. In 2007, a study in Houston, Texas, compared a population of undocumented immigrants receiving maintenance dialysis to a group receiving only emergency dialysis with endpoints of outcome and cost. The emergent dialysis group had more emergency room visits, 26.3 versus 1.4, spent more days as inpatients, 162 versus 10.1, received more blood transfusions, 24.9 versus 2.2, received fewer dialysis treatments annually, and reported more physical pain and lower level of physical function. The mean annualized cost for treating one emergent patient was $284,644 versus $76,906 for maintenance dialysis patients. Providing maintenance dialysis to the 13 patients in this particular study would have saved, in this particular small group, $2,700,000. So again, as we talk about affordable health care, as we talk about provision of health care and the utilization of resources, I think some of the decision making, and certainly when we continue the discussion with Cheryl, we need to also think about how we're distributing things and what we're doing by some of the decisions that we're making. The next couple of things that I thought were worth, again, setting some groundwork for our discussion came in some essays that address topics that I would frame as unable to afford what is needed. And so I'll do the first one, from which I pulled the first quote. This is an elderly geriatric person who presented to the emergency department with chest pain. He had a history of having a coronary stent placement in his left anterior descending coronary artery. And he was prescribed medication post-stent placement, which is the standard of care to maintain the stent. As it turns out, the patient was not taking the required medication because of financial issues. He has insurance, but the copay for getting a month's worth of the medication that he needs is $80, and he can't afford it. So they tried everything they could to get him discounted medicine, but because he has insurance, there's no way to get it discounted, and there's no way to get the drug company to give him on a patient assistance plan. And as many of you know, we don't have free samples. So we're stuck with a person who has a healthcare problem and needs a maintenance medication, whether it's to keep his stent from reclotting, or you could make the same argument for patients with high cholesterol, where we know if we manage cholesterol and we keep it low, they're less likely to progress to coronary atherosclerosis and other long-term, higher-level, more complicated problems. And so the student goes on to describe some of the issues on, in this particular patient, an assistance of $80 for 1 month's supply of medication could have helped deter the cost of a 3-day hospital stay. Although healthcare rationing is essential to provide adequate healthcare to the general populations, programs that assist those who are able to afford health assistance but are unable to afford their high copays and deductibles must be formulated and put into practice. The next one focused on an all too tragic story that we hear, and again, opens some other ethical dilemmas. And this is a gentleman who has a treatable disease, which is CML, a leukemia that's often seen in the older population. He is offered an option for treatment, and there is good treatment for this disease, but that he finds the cost of the care is way above. He has insurance, but the cost of care is way beyond what he can pay, and outweighs his monthly salary significantly. A month's supply of this medication is $4,500. His insurance will only cover part of it, and he only makes $1,500 per month. So in the end, the patient decides to forego life-sustaining treatment, mainly because he can't afford it. This will mean that he will no longer be able to work, he will no longer be contributing into society, and he has a disease that could potentially be put into remission, but instead will unfortunately have to deal with all of the issues of rapid decline. The student says, I really struggled with this issue throughout the clerkship. I understand why hospitals cannot take on patients' care. The hospital has only so much money to keep its doors open. This is even more evident to me with our recent history of storm damage here at UTMB and the possibility of the state not helping us financially. I realize treating cancer can be extremely expensive, but at the same time, there are some ethical issues that are brought forward by this patient situation. Okay, last sort of overview, and then we'll sort of summarize and open the discussion. This is a couple of papers that I thought nicely talked about the responsible use of resources. And the first one is a student who talks about a series of patients that were seen in the emergency room who came in with a variety of problems. Actually, I'm looking at the second quote with this one, but describes a patient with a chronic liver disease who said he has had an exhaustive workup, including a liver biopsy. And even though the liver biopsy was negative for anything that would suggest a particular disease, the blood was sent off for expensive genetic testing. He goes on to say it's no wonder that the U.S. spends close to a fifth of its gross national product on health care. Physicians are practicing medicine too conservatively because they are defending themselves from litigation by ordering duplicative or unnecessary tests. They're also losing clinical acumen from the increasing availability of expensive medical technology that hospitals push for increased profits. Patients continue to neglect their own health even when they know they have a medical disease. And the incidence of preventable diseases continues to rise throughout the country. Complications of these uncontrolled diseases continue to be a problem. Sorry, I seem to have misplaced this one. Well, I think you get the general sense, and I can just tell you the story of this other one that I pulled, and that was a student who beautifully outlined the issues related to a patient who had been seen at another urgent care clinic. And the patient was ordered some very expensive diagnostic testing as part of his trip to the urgent care clinic. And they read the x-ray and then said, oh, you've got something dreadful, I'm paraphrasing, go over to the hospital immediately and get seen. And the student goes on to describe that sitting with the patient and talking to the patient, it was crystal clear by spending time with the patient that the signs and symptoms of what they were suggesting was going on were indeed not correct. The patient had a exposure to some sick children, had no physical signs and no symptoms of what this urgent care center was suggesting was being seen on this expensive test that had resulted in another expensive visit to a hospital. And by spending just some time talking to the patient, they were actually able to send the patient home with no further disaster. And I think this, once again, I thought this story beautifully outlined to me the fact that we are, as the other student said, very technologically driven. We have expensive healthcare testing available to us in lieu of having time to actually sit and talk to patients, having time to actually do a careful physical exam, and to make rational decisions about the tests that we're going to order. So we, as the healthcare providers, are part of the problem by not making these rational and well thought through decisions, but at the same time, the system is working against us by saying you must see a minimum of 10, 15 patients in a half day. You have to get this done, you have to work fast. And when a patient, and later on in the discussion today when we're talking about more specifically the issues directly related to the elderly population, we need to slow down. And that's one of the things I think, as I've read through many of these essays, has come out loud and clear. We need to step back, we need to think about what we're doing, we need to slow down, and we need to rationally and effectively use the resources that we have. So in some of the points that I wanted to bring out with these beautifully written essays, and I think looking at it from the perspective of learners, looking at it from people who are working in healthcare as a healthcare provider for the first time, and again, in sorting through just some of the high points that I could find on these, I think some of the things that I can summarize for you is we've had a discussion about failure to obtain basic care, mainly because people don't have access. And as a result, people are presenting to the healthcare system with costly and preventable complications, with diseases that if caught early and managed wouldn't be an issue. And we particularly see this as in the geriatric population, because it's the age of about 20, 25, depending on when you get off your parents' health insurance, to that magic age of 65 when they get their Medicare and they show up for that first visit, that they already have chronic problems that could have been prevented had they had health care in that interim period. We look at limited access to health care, which then makes the emergency room the only way people can get care, and the only way the emergency room can provide care to the sick, as you all know, is if it's truly an emergency. And if someone comes to the ER and they're not really meeting that, the emergency room has the ability to turn them away. And again, they will not necessarily have a resource where they can get care. So we've set a system up that is encouraging people to get really sick to get into healthcare, which seems kind of twisted in all the things we've talked about. Then the inability to obtain maintenance or life-saving therapy due to cost. And you can argue with some of the very expensive therapies that we have to be careful and we have to be cautious and we have to make decisions, and that's a whole other ethical discussion. But the ability of getting maintenance therapy, things that again can slow the progression of disease so that we maintain a healthier patient, a healthier family, a healthier community, a healthier society overall, are things that we really need to be talking about. And then finally, the way we're using our resources. We have high technology, we have the access to technology, and at the same time, we're using technology in lieu of being able to spend time with the patients and do some of the very foundational and fundamental diagnostics, which happen through discussion and hands-on, and therapeutics, which are discussion with our patients because of the way the healthcare system currently is working. I think that I just want to finish my formal comments with one more quote from one of the students, which says, my dealings with this patient have changed my perceptions of the medical field with regard to overall care and the rationing of health care. My previously held belief of pay for services in all instances has significantly changed. In a situation where limited funds are available, I believe that all patients have a right to be considered for treatment, not just the ones with the right disease. And I thought that kind of really drove home a point. So with that in mind, we're going to open the discussion, and I'm going to ask Dr. Cheryl Vianney from the Institute of Medical Humanities to come forward, and David, for as long as you can stay, again, providing a student perspective, if you'll come forward, and we're going to shift to the table and open this for discussion and comment. Okay.
Just to preface what I hope is an open and an involved decision, I think everyone will admit that our healthcare system is seriously deranged, that we have made some very short-sighted decisions about how we do things. The politicians versus the judicial system have made differing decisions that don't really seem logical in their application as far as emergency care versus preventive care. And I think our students' papers here have highlighted many of the ones that we see on a daily, weekly basis in our setting, in our hospital setting. And we would like to be able to provide all care for everyone. That's sort of, I think, what most of us came into healthcare to do, to take care of people. And we are faced with an enormously expensive system that is difficult to afford, And anytime we look at trying to make adjustments to that system, whoever feels they're going to be shortchanged rises up and protests and talks to their congressman, and we find that we don't really make what seems to be a lot of progress in that setting. So with those very brief statements, and the other thing that Karen and I talked about is as a nation, we respond to emergency. We have that rescue phenomenon that, if we want to get out there and save lives. And so we are going to do that. We do that in the emergency room. We do that through much of our technology. What we haven't been so willing, although we voice the need for preventive care, for maintenance care, we haven't been so much willing to fund that. And that is one of the basic discrepancies in looking at this system. We'll pay for transplants, we'll pay, which may be certainly financially beneficial, particularly when you're looking at kidney transplants versus dialysis. For other transplants, maybe not so much physically responsible. But we pay for all sorts of technology and life-sustaining treatment, and oftentimes it may not be in the stepping back and looking at it from a societal perspective. It may not be the best utilization of our money. And those are very difficult decisions to make and agree on, for any of us to agree on. So I think what we'd like to do is, do you have anything you want to say, David?
I think also as we enter this discussion, the other sort of tactic is, we could sit here and argue, and there's no argument that the system isn't working like it should. So what can we do? What can we do at a grassroots level? And what can we do as early as with our learners? Because we're in an academic setting, we have all sorts of bright ideas and young minds here that have great ideas. What are some of the low-cost creative options that can be put into place that can make a difference so that people really are empowered and really can make a difference? So the problems we know, and I think we agree, so let's also make sure as we discuss this that we offer options, or even if you have great examples of ways that people have impacted things. I'll just tell you very briefly, when I visited New Orleans, they've set up these fantastic community healthcare centers in New Orleans over the last 5 years. And they serve the neighborhood that they're in. And it was such a beautiful model for healthcare. I was like, why isn't everybody not doing that? The community healthcare center there knows the people in the neighborhood, knows their problems, knows when they come in, knows when they don't. And there were some really nice things, and the medical students all went there. And the nursing students all went there, and the other, health professions students. They go there and they work with the patients, and they also learn. And so it's a win-win situation for everybody. So that's one model I would throw out that might be worth talking about. But again, let's sort of see what some of your ideas might be, or some of your reactions.
Anybody want to talk about those?
Let's start off. My name is Rebecca. I'm a social worker on campus, and I work for the community health program. We're an outpatient case management program, and we work specifically with uninsured chronically ill patients. So this population is very familiar to me. I was saying David's been involved with the St. Vincent's House Clinic here in Galveston for a while. And I think that environment is a wonderful place for medical students, if we're talking about learners, to learn about people in need and how to treat them. The providers there are very familiar with helping people who have big needs and working to find answers for them. And we all know there are very few answers for people with cancer. There are very few people, very few answers for people with end-stage disease. But working at the community health level, getting to patients, getting to people when they're still early on in their disease, or if they're advanced, but still at a point when they can make changes and come back to that, I think is important. And if we could enhance the interaction of our medical students in environments such as St. Vincent's or other community care areas, I think they would benefit greatly from that.
Absolutely, I think that's right. Do you want to talk about St. Vincent's
Sure.
or make some comments?
So I started going to St. Vincent's when I was a first year, right after Hurricane Ike, and we went out to the neighborhood and tried to round up every patient we could find. And really, St. Vincent's has been an extremely important part of my medical education. Before I started on wards, I had seen 1,300 patients at St. Vincent's, and up until now, I'm still not haven't doubled that over the last year. So I've seen more patients at the free clinic than I have in the hospital, and the effect that it's had, not only has it enabled me to help bring the patients that leave the hospital to St. Vincent's that could benefit from being there, even though it's a student-run clinic. It's given me a much different perspective than I think a lot of my colleagues in my class. And I think in Galveston we have a special sort of place because the faculty that are here almost universally want to teach. And so we have a large group of faculty that participate and volunteer their time week in and week out at St. Vincent's, primarily because they love teaching. And that is pretty much why the clinic runs. I mean, the students always want to get involved, but the faculty, that's the reason it happens. And I think the model between having a medical school and community centers is unbelievable because not only are the faculty that want to teach there, but they are some of the best faculty at UTMB because of that fact. So we get a pairing between people that want to learn and the best in their field. And, we get specialty care that way, and we can, provide a medical home for patients that are really homeless or lost or without hope ever of getting care in this country or, in their future. So, in my mind, that model works pretty well, but I am definitely biased in the fact that that's how I was brought up, so.
I'm Steve Shelton. I'm the director of the East Texas AJAC. I'm also the course director for one of the medical student 4th-year ambulatory community selectives for a course that gives students credit for going to St. Vincent's for a clinical experience. The St. Vincent's Clinic has been around for over 30 years. It is a very long-standing and enduring clinical setting for Galveston's disenfranchised community, essentially. The essays that I get from the medical students that are in that course experience, which is actually the second most popular after the internal medicine ACS, which includes all the medicine specialties, are really amazing. They provide some fascinating insights. And I really just ask them one question, and that question is, why do places like this exist for patients to come and see a provider? And that question stimulates a lot of interesting thought by the students, and which turns into very interesting insights as well, very similar to the ones that Dr. Sauter used to illustrate the points that she chose to make today. Student-run clinics are common all over the country. and they're common internationally as well. I think David's observation that it has provided him tremendous insight and a volume of patient care that hasn't been matched yet in his formal campus-based clerkship experiences is a very significant statement.
I think it's clearly important to the medical education of our students. I think it's also important to the education of a broader education of how medicine works in society, which we don't necessarily teach very well in our curriculum. We're trying, but...
Well, I liked your comment about the community-run clinics, and I don't even know if clinic is the right word. I had the opportunity to go on a mission trip to Mexico maybe 5 or 6 years ago, and you saw whoever came there, and what was really interesting about it is you had no resources. You had a dirty couch and a piece of paper to work with, or a towel that was in the bathroom. I mean, you made do with what you had, and I think one of the, to get on my soapbox, I think one of the issues we have here in this country is people want the head doctor, they want the most popular treatment, they want all the tests done. We don't settle for some basic things that really would help us. And I think the other thing about a community type of thing, because I've also been able to do a lot of lectures in the community, just in general about arthritis or about Alzheimer's, just about some different chronic diseases. And what a lot of people don't have is just a basic understanding of what's going on with them, what's normal, what's abnormal, what are things to be concerned about. And like the people that y'all talked about that don't access health care until it's an emergency, maybe just basic education. And no, maybe we can't charge for that as a health care provider, but that's certainly something we all would be willing to do as a person who got into this business to help people and to make things, to kind of decrease the issues that go along with chronic diseases. And maybe that's a solution, to kind of catch it early, give people education, information about their health care so that they can make good choices and they don't wind up with terrible complications from something that could have been prevented.
And I think picking up on that, I think you make a really, really important point. Again, as we look at what can we do at a grassroots level, we can't fix this big system, but we can start to infiltrate it with power and good things. And there was a series of presentations, as many of you know, that were given to the community through President's Cabinet Award here. And I'm embarrassed to tell you, I'm going to forget the actual formal name of it, but they were once a month, and it was a dinner, and they would invite a speaker. And I had the amazing privilege of being asked to speak at that one evening, and spoke about what I know, which is colon cancer screening, because that's just kind of one of the miseries of becoming mature. And I had two reactions to that. I just talked about, why we do it, why it's important, and what it is, and what it looks like, and kind of what we're thinking. And it was just a very relaxed talk. And two things happened. One is a bunch of people came up to me afterwards and said, I had that done and I never really knew why. And the second thing was I had several people show up in my clinic afterwards and say, I didn't understand how important this was for my general health. And I knew I needed to have it done, but I didn't understand why. And I think a simple 1-hour community presentation can help people. As we read through these, one of the students said, we need to start this education in grade school. We need to start empowering people to understand about their health so that they can make good choices. And it's not the don't eat this and don't eat that and, go do this, but really at level-specific education can start happening publicly, and that's stuff that anybody who's interested in healthcare, but particularly our learners, again, whether it's School of Health Professions, School of Nursing, School of Medicine, the graduate school, we can work together and we can kind of do some of these things, again, to combat some of the problems in the healthcare system. So I really appreciate you bringing that up, thank you, because I think it's, again, another grassroots effort that really impacts more than we realize. Naomi, did you have a comment?
I just had a couple of things, but one of the things, what can we do at the grassroots level? And especially after living in a country with socialized medicine and the different way that people see what is expected and what they want. And in England they were shocked about how many TV commercials we have about different drugs that everybody wants after they see the commercials. But I think that part of it is in our country, it's who speaks the loudest gets heard. And that's sad because you have beautiful stories. I mean, they are just very, very powerful. And one of the students even commented that, I want my voice heard. And I wondered if you had ever thought about publishing this in a book or in some way that it gets out to the public, not just in medical journals. They're beautiful stories. And it shows another side that we don't always hear about in this country.
I summarized when you were reading the essays few words, and I will read first these 4 words: education, rationalization, providing care, and legislation. So when we say that there is lack of services for a certain group of the population, legal or illegal immigrants, doesn't matter. But there is also waste of resources and a very costly system. If we will do the same study on every medical illness in this country, we spend too much. So one of the purposes of education where us as health system could be very involved in education is that we all shall be the gatekeepers of the system. We hate when legislation came upon 15 years ago or something and started putting gatekeepers, because a person in a desk without medical background or your own professional background, therapy, nursing, or whatever, will sit in a desk without knowing the individual case and having a personal relation with the patient, will try unlimited resources that we really experience a very painful time where that's not the way to limit the expenditure. But if we all, along with learning, what we do every day, learn to be the gatekeepers. So we don't wait for the test to tell me what's the problem with the patient, but I always beforehand, before asking for the test, ask myself a question: what will I do with the result? Positive or negative or serendipitous? And if I'm not going to do anything, I'm not going to ask for it because it's $10,000 from one little pig. It doesn't matter if you have private insurance, Medicaid, Medicare, or no money. There is only one pig with certain amount of money that is limited. And I ask the students, if we all at different age groups think about this is only going to be worse if we don't make a change in the way we spend. So we are spending the money that will not be there for when I grow older, because I'm throwing it through a drain, because I'm spending more than. And the most beautiful thing that Karen teaches, I teach, all of us that teach medical skills, is that by doing what this, you just mentioned the ABC, but having a personal relationship with patients and going back to the ABCs, we can provide a huge, how come you can do a good work at St. Vincent's without a lot of technological resource? Because there you are using your ABCs. So that as a medical professional, as a healthcare professional, we can all participate by being the gatekeepers of the system, using our brain power on top of any technological power, like knowing and being able to communicate with patients that our brains have more information for them than any scan or MRI or things. So we have that certainty that we are letting that certainty be get lost in the system. So that's one part of course. From the last word I mentioned is legislation. We also need changes in legislation, because charity clinics are are not the answer. That's a step back into the 18th century. We need a move forward, changes legislation, so what you do at St. Vincent can be done in a proper way, because there you are limited also, but you need some technology there. And we see you need some less technology here, so we need a middle term, so we can modify the society, not only the patient, in terms of education. You mentioned in another slide, patient and then society. We are all part of the health system. The advertising industry, the schools, the teachers, all the society are part of the health system in the same way that having healthy waterways changed life 5 centuries ago. So we all are providers, but we need to participate in all this change until it gets in a good way into legislation, but started doing a personal change in how we can also limit expenditure.
I wanted to make a couple comments. One was the free clinic. I think the answer is to get rid of insurance. Our medical providers are excellent. We have good training. I'm a nurse practitioner and we provide primary care, but it's the insurance that is messing up our system, because everything works beautifully at St. Vincent's and other charity clinics. I think we should have more charity clinics where everybody's an equal. You come in the door and you're treated, you're taken care of, you're listened to. But because we have to bill for education, you have to code certain ways to get reimbursed, that's what's destroying our whole medical care system, I think. So I don't know how to fix that, except go work in a charity clinic.
But the issue is, it is okay to be edgy, and it is okay to say, let's do away with this. But what we have to do, I mean, it's a huge cultural issue that we're dealing with, and I'm reflecting on some of the things that Oma said. For any of you who have lived outside of the United States, which I had the opportunity to do as well, and lived in a country where there was socialized medicine. And you go and you get health care because it's part of what you do, and as a citizen you're working and you're paying into the system, and you're taking care of yourself and you're taking care of the rest of society, and everybody gets the very basic needs. And yes, you can't get some fancy elective procedure done unless you can afford it, but that was the reality of it. But you could get basic primary health care. And it's a very different system. It is not a system that would easily be accepted in the United States because of the way the rest of our culture works. But there is basic insurance for everybody, and then there's a more extended insurance for those who could buy into a higher level. So there are models for it, but they're almost counterintuitive in the way that our society is set up. So it's going to take a lot of education, both at the level of our healthcare students, our healthcare providers, but it's also going to take a lot of education, I think, in our societies, which will start in little pods and then can grow into bigger areas. But it's certainly something, and certainly as we've talked about healthcare reform and all the issues that are being discussed, you can see that this is a topic that people are very sensitized about. I mean, we in this room could fix it, right? We could go out and we could fix this because we know what's needed. That's the sad thing. We know what's needed. The reality is making it happen.
And I think two things. I think we need to be involved at a level higher than just the individual patient level. We are the experts. The people in this room have a very important perspective. How many of you have talked to your congressperson? Well, good. More than probably in others. And I think you need to keep that conversation going, and also need to keep that conversation going through some of the professional organizations that you belong to. I think the other thing is we need to be creative in our approaches, and these may not, certainly creative as an individual, as Maria's talked about, but also creative at a higher level. And care management in our hospital is doing a little bit of that when maybe we need to cough up the funds to pay for something that we can do at home much more cheaply than we can do it in the hospital. And some of that is difficult, but some of that just takes some creativity and some people that are willing to use funds in a different way that are going to be spent anyway. So it's encouraging our students, our residents, our physicians to think about, is there another way we can do this that makes more sense? And I think we go back also to the education. We need to educate on an individual basis, but we also need to educate the community that there are lots of people that are out there saying that there is no health care. My only health care is coming into the emergency room when I'm really, really sick. And let's get some more information out there about free clinics, Planned Parenthood, other ways that you can access free care. It may not be what we'd like to provide in that basic care from everyone, but it keeps us from some of the situations that are really outlined in this paper, where people just haven't even touched the healthcare system for 10 or 15 years and are in such horrible shape that there's very little that we can do for them. We have a
Last comment.
Hello. My name is Jin Hyung. So I'm an assistant professor in internal medicine. So what I want to focus on this lecture is resources are very limited. So as an economic point of view, not everyone can use healthcare resource. So you mentioned some kind of free clinics, right? And so my question is, do you know why we pay co-insurance and co-pay even if we pay the premiums in hospitals? And there are a bunch of experiment researches. So if we without the co-pay or co-insurance, the people use endless. They use the healthcare endlessly. So in the case, who pays for that old amount? So if we have free clinics, then who pay for that? I can use healthcare by free. It's good for me, only good for me. But in society point of view, probably the President Obama will not pay for that, right? So and rich people, they do not want to pay for that. Healthcare burden, who gets some healthcare with free. So there's no free lunch in the world. And also, in USA, the national healthcare expenditures account almost 18% of the GDP, right? That is the most highest healthcare expenditure in the world. But their quality care is only probably 20th rank in the world. So their quality care is not that much good. But we use so much of expenditure of monies in healthcare. But so I support the Obama's healthcare reform. So that right now we have so many problems, right? But it takes some time. But in the end, I think what my point is, we need to think about society point of view, not just individual experience. His experience is very good. So we need to support undocumented patients. But in society point of view, we should not pay for that kind of free health care to the patients. But I know it is very unethical issues, but we think in more and broader.
Okay. I think that, Tony, can we wrap up? Okay. So again, the purpose of this forum was really to think about a couple of things. One is to recognize from an educational standpoint that we all, regardless of our disciplines, are working with learners of our own discipline and of other disciplines. And I think some of the discussions that we can continue to have with our learners is not only, what did the CT scan show, but what did you hear, what did you feel, what did you smell, what did the patient say, to continue to encourage those kinds of discussions as we move forward. To look at our role as educators of our future colleagues and also of our communities. So that, again, as we reflect on some of the things that the students are having their aha moments and their epiphanies as healthcare providers, that we can try to provide some additional resources for them and also for the people that we're serving for the future. I don't know do you guys want to make any final comments? We can sort of wrap up. I really, really want to thank David for taking time out of his clerkship to be with us. I think, having a student here and a student voice is always a real gift. So thank you.
And I just want to say, I think, as Karen said, it's important that we recognize how difficult this is for students, that when they start their third-year clerkships, they're really confronting the reality of they can't do everything for everybody. And I think that's something that they came to medical school thinking they would be able to do. And so I think it's important for us to reflect on not only what we need to do in the future, but also trying to maintain that humanness, maintain that desire to care for patients, and that is so easily damaged when we have to not care for patients in the way we wanted to when we started out this educational process. So thanks everybody for their comments.
All right, welcome back. One thing with this series that's really amazed me is I had no idea what direction all this was going to go. We couldn't plan it. We couldn't say, oh yeah, this is what we're going to take on and tackle, and these are going to be the issues that we're going to really look at closely. So I'm really pleased that I think it's evolving into a forum that we could really bring out what the issues are. And we've done well, I think, the first two sessions getting the basics down, and now we could really take off as we did with the previous panel and work with the students and the message of education. This part of the session will focus on actually addressing primary care and some of the things that we've tried to address. And many of you are familiar with primary health care as being the first line of defense for any undiagnosed illness. Most of these are, could be related to working into communities, making that first point of contact with the healthcare system for many individuals. And this applies for all populations, maybe in different ways, in terms of pediatrics versus geriatrics, but generally that first point of contact. And that's really going to set the stage for how things develop afterwards. What's also important is that the services are provided through a wide range of basic health conditions. And so these could be not just organ issues or diabetes, but a lot of mental health issues. We deal with depression a lot, for example, with older populations. The patients are followed over time by the same primary care providers. Continuity of care, right? We hear that a lot, so that's another point. I'm just making the main points here when we come to primary care. The services are coordinated on a higher level of health systems that can provide more specialized care when needed. All right, so that's something else we keep in mind. And the service reach out to marginalized and underserved groups. That's always a goal that is tried. So what I want to talk about, I'm also trying to make this a little more global. We really focus a lot on what's happening in the United States in terms of healthcare reform and healthcare systems, but sometimes I think you step back and we can look at what other groups have done, maybe for other countries, for other populations. I came across this article by World Health Organization about age-friendly primary health care, a project that that was done in 2002. It's a little dated, but I think many of the points still apply. And so the goals of the project were to sensitize and educate health providers in terms of the specific needs of older adults. You'd use focus groups to find out what is it that the older patients want with their healthcare system. Okay, that's what we're looking at. And you're looking at the principles of the primary healthcare centers as being tools to increase awareness. What is it, the things that these older patients are talking about that they want to see, and to empower them over time. So, you're finding out that we really need to work on some of the attitudes and levels of education, some of the things that came out in the first part of this session. How well is the training in terms of, are we covering what the health needs are of older adults, older patients? How do we adapt the management systems? It's chaotic, there's too many forms. How do we help older patients deal with a system? And we've talked about this a lot, and sometimes I feel like we dance around it, but the thing is, the reality is there's a lot of forms, and there's a lot of things to do, and can anything be done with that? Or how can we help patients that are dealing with so much red tape maybe or something? And finally, access issues. Making an appointment is one thing, getting there is another. And then the physical environment within within the facility. Is it safe? Is it accessible? Do they have to wait a long time to see somebody when they're tired and it just doesn't work? And then are they being addressed if they have vision and hearing problems? Okay, and so these impairments like those are pretty common, obviously, with older patients. So real briefly, this was a focus group of 36 groups were actually looked at with a number of countries, in developed and developing countries. There were provider groups were also looked at in terms of getting participants. And these were just some of the results that you could look at. I talked about attitudes, training, and education. There were gender issues. Many of the older adults felt that the issues affecting the female patients were not looked at as seriously as the male patients. It's out there. It's something to think about. I don't think ageism and chauvinism is something we really want to talk about in healthcare, but who knows? Maybe we do. We always have cultural issues. That came up a bit as well in terms of more than just language barriers. We have to look at customs of different cultures. The healthcare system, again, we talked about in terms of getting appointments, making forms, cost. Obviously that's going to be a big issue, and it's a big concern. And then we talked about community care, continuity of care, and it's being fragmented. Is it carried over from one facility to another? If you're seeing multiple health providers, does one talk to the other so we know what's going on? And then the special consultation or clinic specific to health needs for older patients. Is that really something enough out there that they can go to a health provider that can get the right kind of information? And we talked about the right a safe physical environment. So a lot of this is in here, right from the mouth. So and then we're going to carry this on, by the way, real briefly, real quick, because we're going to get to the panel. We're going to carry this next month. This is going to be carried through. I got an email. I just love my BlackBerry. Dr. Goodwin, the director of Cecilia Center and Aging, will be giving the first half of the May 18th session, looking basically at the realities of providing health care for older adults. And I hope you can make that, because that's going to be really good. And then the second half, as I mentioned, we're going to have a panel of older patients from the lifelong learning group here. So I'm looking forward to that. I hope you can make it. So moving on to our panel. I asked them to just give a brief introduction of who they are, what they do in their role in healthcare, and we're going to start with Dr. Karen Sauter.
Y'all heard enough about me today. So I'm in the Department of Internal Medicine. I do gastroenterology, but I'm a trained internist, and
So, me too. Okay, I'm Andrea Wirt, nurse practitioner in geriatrics, the outpatient clinic.
I'm Steve Shelton. I'm a physician assistant, but I'm also director of the East Texas Area Health Education Center and assistant VP for community outreach here at UTMB.
I'm Lisa Moore. I'm a care manager and also a social worker, part of the, on the geriatric base unit.
Rebecca Galloway, I'm a physical therapist, faculty in the School of Health Professions, and I've also had a lot of experience working in the acute care for elderly unit here at the hospital.
I'm Gretchen Stone, and I'm chair of the occupational therapy program. I've traveled with the interprofessional teams to Nicaragua and with Frontera doing home visits in Nueces County.
Okay, thank you. We have met briefly to discuss how we wanted to do this. And I think I will start it off with just looking at, we have some panel discussion questions, just some thoughts and some points that we might want to get started with. But this will take off. It will go in so many different directions. An interprofessional panel is the way to go in terms of looking at healthcare for older adults. And you will have any opportunity you'd like to address something that the panel says and talks about. Okay, so this isn't just sitting there and listening. Okay, we want this to be interactive as possible. So looking at the first panel question, and you have a handout here, I'm just going to read it basically. The concept of primary health care has not always been understood in terms of its role and importance within the overall healthcare system. A lot of what I've looked at is through this WHO article, and it states that primary health care is the principal vehicle for the delivery of health care at the most local level of a country's health system. Yet, with that in mind, are we adequately addressing the healthcare needs of older adults? If so, how are we doing this? If we're not, well then, how can we do it, or can we do it better in terms of alternate factors and ways we can work it through? And all right, just for the sake of argument to get started, I'm going to start with Karen, and we can either work our way down, or I'm sorry, we're going to start with whoever wants to say something.
I guess I'd like to speak from the perspective of my discipline, which is occupational therapy. We're particularly interested in how people live their daily lives at home. How do they manage at home? And I think that when we're part of the primary care team, we're looking at things differently than the traditional medical team looks. For example, why aren't people taking their medicine? Why aren't they following all of the educational guidelines? I think we keep answering why, and so I would encourage all of us thinking about primary care to look at the utility of community health workers and of people that actually go into people's homes and look at some of the underlying reasons why there's problems.
From a physical therapy perspective, there's a lot of ways that we look at primary health care. But in an ideal circumstance, we would have better access to older adults before they get to the physical performance status that's so low that they can't get through their daily life without help. So too often when we get a referral or we finally get access to an older adult, they've had months or years or a prolonged period of what we call functional decline. And there are a lot of markers that we know we can use in our field to identify persons, so very simple things such as measuring their gait speed on a regular basis, which anyone can do, even the patient themselves, and takes seconds to perform, where we could catch them when they're sort of on that slippery slope and could provide some interventions much earlier.
From a social work perspective, we look at patients in systems, in forms of system, how they're relating to other systems like the UTMB system, the hospital system. We look at the family system. We look at if it's a closed or open system. do they allow services in? Do they allow, are they basically not allowing anyone in, just stay in a closed system? We look at environmental factors, we look at their emotional well-being, we look at how they view others and how they view the healthcare system. And what we do is we try to get in and educate them on how to access services, whether it be healthcare services or services in the community or resources that are available to them. And we try to match them. We try to make sure those systems stay open, because a closed system, you can't get in. You can't get any information in.
As the panel started their comments, I was reflecting on the history of the physician assistant profession, which started in the 1960s and was grounded in primary care medicine. My own practice experience over about 20 years has been in family medicine, in rural community, and now in UTMB practice in prior years. But I think there's irony in the question, because the rise of specialization in medicine and then in all subsequent or successive disciplines really only occurred a few decades ago. In healthcare, the general practitioner was the anchor for our parents and for some of us as the primary care provider. So just in my lifetime, in my professional lifetime even, we've seen a progressive migration and further definition of specialization. And I think that's also true of the disciplines that are represented at the table, where if we look at each one of us here, we can describe specialties within our disciplines that have become defined and very well delineated. The other thing that I would add to this question is that PAs have increasingly become specialized as well. That's been a progressive trend in physician assistant practice over time that's primarily market driven. The jobs are available for PAs in the specialties, and they take them, as opposed to working in a primary care practice setting. That's a little different than the NPs. The NPs have stayed a little bit more grounded in the primary care disciplines than have the PAs over time, over the recent trends, I should say.
From a nursing perspective, to answer some of the question about primary care, actually how we're doing here, just on a personal level at UTMB, and I think any of the academic areas have the ability to do that with the multidisciplinary group that you have here, to really be able to have access to that and be able to provide that. What I see as a challenge with primary care, though, is out there beyond us, where you don't have that access to a social worker or to your physical therapist, occupational therapist right around the corner. And how do you make sure you're looking at, especially with the older population, that big picture of everything that's going on with them and their needs? And I think that'll be our challenge.
And I may give a very sort of skewed look at this, but because my practice now is only subspecialty care, but people have direct access to me, I can't tell you the number of times that people are in my office and I say, now, who's your primary care provider? And they either say, I don't have one, you're my only doctor, at which time I go, oh, that's scary. Or they say, I don't know the person's name. I go to see that person, but you know what? I'm not sure of the person's name. I'm not sure who he is or she is. But the irony is that they often know either the nurse practitioner's name or the PA name in the practice, but they don't know the doctor's name. And I think that really speaks to locally that the system works and that there's a lot of interdisciplinary stuff. But we also, again, coming from, because I've done both primary care and subspecialty care at UTMB, and practicing now only as a subspecialist, people are accessing the system through us and don't know all the other options that are open to them. And I think, again, I keep harping on education, but it really is my thing. Getting out and letting people know, you're seeing me for this, but the fact that you're in a wheelchair is not an okay thing, and you could get some help, and this is where you can go for it, and they don't know what the resources are. So I think I see it from a slightly different spin, but it's knowing that you guys are all here, and I call enough of you enough of the time, that we really, again, need to make sure that the avenues to access are open to the patients and that they're aware and know what's available to them for help.
Any questions or comments? After each one, I'll ask if there's something you'd like to comment on or something that you kind of felt moved by or something that you want to say.
Well, I'll comment that I'll admit that my primary care doctor is my OB-GYN. And I mean, he recommends that I go have blood tests, have my cholesterol checked, make sure I schedule for my colonoscopy since there's a family history of that. And I think as a consumer of healthcare, I know what my resources are to a certain extent. But I kind of ration how I use my healthcare dollars because you can't afford everything that you want to do. And I think those of us who kind of know don't really utilize the system well. And so I know, and we're all have experience that those who don't know the healthcare system, don't know the resources, certainly don't benefit from all the things that are available to them.
I think that's a really important point. The audience today, us included, have to be recognized as very knowledgeable in the healthcare system. And for the most part, we know how to maneuver that system to meet our basic needs. Occasionally we'll meet a road barrier, but we also know what the workarounds are for the most part. And that is not true for the general population. It just simply isn't true. You know, sometimes I think it's also not true for the provider in the community setting, and I'd be interested in what the remote sites would have to say about this. For example, I do see a primary care provider, I see a family practitioner who manages my care and through whom I have had occasion to see a specialist. The specialist doesn't communicate back to my primary care provider. They stay isolated in their caregiving from the person who's primarily responsible for my care. And I think that separation is true in between most academic health settings and specialty provider settings and the primary care providers. So that the primary care provider setting, whether they be in an FQHC or a community health center or in a free clinic, end up not knowing as well sometimes what the resources are available to them in the system and how to access those resources. Even the providers sometimes don't know that. And so I think that's really a particular challenge for the system. And I would invite our remote audience to perhaps also comment on that.
Are there any comments from the sites outside UTMB that we're connecting to on Steve's points? Because one thing I did want, I'll give a point in a second. Go ahead if you want to say something. Because what I was thinking is I've been introduced to a lot of small town medical care in my travels through the Piney Woods, for example. You know, connecting with our partners and our consortium partners with the GEC, and it's a whole other world, obviously, and I love it. But I love this world too, you know. But the thing is that really gets me is that they know the person. There is a person that they can identify in their community, and Mark in Piney Woods, you know who I'm talking about, who's knowledgeable, who is the person, the gatekeeper, holding the keys of care. And this he's a physician, but he's also their pharmacist. He could be their priest, their therapist. They're over for dinner. He invite him to dinner. He comes over. They talk about things. And it's that kind of community, and it's age friendly as we try to do. And he besides being brilliant and knowing the major needs and anything that comes up of his clientele where he is by name, including their children. It's really impressive. But can we have at that level in a larger area that's a little harder to maybe coordinate, I think. Any comments from the site? Yeah. Okay. All right, we're going to move to the second question. And in a way we've started talking about this because we're talking about now some barriers to providing adequate care or prime care. And so in terms of making it friendly and the special needs of this older population, it's a noble goal and it's necessary. And so how can we try to assure what's considered to be age-friendly care?
Are we going in line again? I would like to speak to the issue of executive functioning. I think we assume that people can make decisions and judgments, and really they have a lot of difficulty to do it. And I think you can test it in the clinic. I'm playing a broken record here, but if you watch a person in their home doing their daily things and shift there's simple modifications. People want to stay at home, they want to age at home. And it's been my personal experience that they're more impoverished and have less access. They want to stay home even more. It's not like they strive to be part of a big medical center. They want to stay at home. So I would encourage us to check, and things like vision, you say, how's your vision? Oh, it's fine. You say, well, look at the TV, does that seem clear to you? Well, no, I can't really make out the images on the TV, and it's blaring, so you're screaming at them. So you know that there's vision and hearing problems.
Right.
And those people are at risk, but those simple things can be addressed at home relatively inexpensively. And I think we forget the low-cost individual interventions that are available.
One thing I think of in terms of the simplest of interventions that without any equipment we can give, and that's activity and exercise recommendations. From a physical therapy standpoint, that's a lot of what we do. And specifically what I often have to step back and think about is tailoring that to that person's whole life. I'm not talking about whether they have TheraBand at home or whatever, but in their day, where are they going to fit that in? And me personally, I have significant challenges with small kids at home and trying to work on a PhD and grading papers and preparing lesson plans and trying to find a little bit of personal time to fit those things in. And older adults have lives too. They're filled with what they want them to be filled with, and some of them are still working, and some of them are helping watch grandkids and do all sorts of other things. So finding out a little bit more about their life to be able to say, okay, let's not begin with 100 exercises. Let's begin with prioritizing the 2 or 3 things that would help you, and here's how it would help you. And walking through your day, where can you fit this in? And making it a little bit more of a planned partnership rather than just a prescription.
From a social work perspective, working on the ACE unit, we have patients that come in all the time, and we're looking at their social support systems, looking at who's available in the home. And what I'm finding, and this is true, that if their basic needs are not met, the doctors can come in and explain everything to them, but if the basic needs, shelter, food and housing, and all those things, if those are not met, you can't go any higher. Education, you can educate all day long, but if they don't have the basic needs met, they can't go any further. And so what we try to do is we try to use some of the county resources in the community, the CAP program, I think we talked about that, St. Vincent's, but we try to get them in and let them know that we can, and we try to provide it before they leave the hospital, because if they know there's a way that they can get these services, they're more apt to listen. So then when we're trying to teach them about their healthcare needs, they can participate in the care, but they don't participate in the care if we can't provide those needs. And we see that, we don't see it as often, but we do see it. It's becoming more often with the high price and cost of health care and with medication prescriptions, and most of our patients are now, it's getting close to October. It's getting close to the end of the year and they're falling into the donut hole. And so those things, if they can't get their medications, you just can't go any further. And then they choose to say, well, I'm not going to get my medications today because I have to have this, I have to pay this, I have to pay this. Then they're taking care of their babysitting their grandchildren, and or else they're helping their adult children out who can't support themselves. So it's a lot of barriers that prevent them from even understanding the healthcare because we can't get these other things solved. And so we really have to start with for us, we have to start with those basic needs, and that's what we focus on in an inpatient setting. We have to make sure that's okay and in order.
I'm honored to be a member of a federal Health and Human Services Advisory Committee that looks at interdisciplinary programs. And one of the things that I have observed and learned from the discussion of that committee is how things have changed over the last decade or so. And teachers in the health professions are more aware now of the importance of relating to their students the value proposition of the other disciplines that may be involved in the care of a patient. I can remember a time, really not all that long ago, where students didn't really have any exposure to understanding the root causes of illness. What are the things in the home that really precipitate or aggravate accidents and illness for individuals? And that is so important in the elderly patient. And I think students now are learning from each other. That's come about for a couple of reasons. UTMB, in its Southern accreditation, by the Southern Association of Colleges and Schools, was dinged basically several years ago for not having a good interdisciplinary program, ways for students to learn from each other. And we have a mechanism now on campus that stimulates more dialogue among faculty and among students, and have opportunities for students to share in their learning and share with each other their learning. And I think that's really important. The testimony that we hear as a committee has also highlighted the fact that the accreditations for the various disciplines has really, until only very, very recently, had any expectation of interdisciplinary learning. And I think when thinking about how to eliminate barriers, it means that I, as a provider, know what contribution a social worker and a physical therapist and a nurse practitioner and an occupational therapist and a physician working together as a team can make for any individual or group of individuals collectively or in a community. So I think that's very important to think about. And that is a change, and I see that as a progression or an improvement over time for the folks. Somebody's calling, Tony? Ding ding. Maybe that means somebody wants to talk out there. So I'll be quiet and see if there are other questions.
Do we have a question coming in? Sorry for the lack of the volume there, but basically we're talking about some of the factors that we've discussed previously with the health literacy and communication. The hearing issue. Many times they see that they're talking, the health provider is talking to an older patient and simply can't hear what they're saying. And so, right, and that's where, that comes up, and then we try to be aware of those. I mean, I think that's sometimes hard after a whole day to remember, but anything in terms of those real basic factors.
Yeah, I think we pretty often deal with that. Hard of hearing patients having to adjust your own speech, being creative, and having them be able to hear you, whether you're going to have to write things down and have them read them and respond that way. Put your stethoscope in their ears and speak to see if they can hear it any better. I mean, there's some creative ways, but that's definitely a time-consuming patient, but very well worth taking that time if you're going to try to achieve your goals. Another barrier that I don't know that we've also talked about is access, actually getting to clinic. I deal with this every day, of transportation, of getting to the clinic with so many of our elders not driving. And I'm sure there are many communities that don't necessarily have low-cost options that we have here in Galveston. And even the ones we have here are limited in being able to have a quick turnaround and seeing a patient. But many communities, I'm sure, they're having to spend money for a cab or something to get to the visit, or just foregoing and waiting on their care until they have a family member who can take them. So I think that's a real concern of what we deal with. The other aspect, just to looking at an age focus, is really to evaluate from a psychosocial perspective what are really, especially our frail elders' goals in that point of their life, that's really going to direct how we're going to access specialists and deal with many of the things that we might do with the younger population. So your very frail elders, evaluating where they are in their life, what are the expectations they have, and maybe you should be realistic at that point, and how do you deal with that?
And I had also sort of jotted down the concept of access to the clinic, but then recognizing that, again, in our clinic, which is a serve all clinic, not just focused on an elderly population, although we see many, many elderly patients, our clinic is not set up to facilitate the care of an elderly patient. We have no electronic or electric exam tables. So for us to be able to physically examine a patient, we have to get them on a step-up exam table. And you can imagine, I also work with the trainees there that will come in, the patient's in a wheelchair, and I'll say, well, did you get the patient up on the table? Well, no. We just examined them in the wheelchair. And I was like, you can't do a physical exam in the wheelchair. You have to actually get the patient on the table. But you recognize that how difficult that is, and there are safety issues too in a clinic that's not ready to deal with that. The other thing probably really striking to me, again, because I see patients who have seen many other physicians, is we do medicine reconciliation, which everybody does. But we'll ask people, who'd you get this from and who'd you get that from? And they come in with the plastic bags full of drugs with 6 different physicians' names on them. And then the reconciliation is, who's coordinating this, who's taking care of it, and you've got 3 drugs in the same class you've got from 3 different physicians, which to me, again, is very scary as we're recognizing the fall risk, the confusion risk, and all the other things that we're seeing. So the barriers, a lot of times, I think some of this was discussed in healthcare literacy, is the patient's understanding of their own care, the ability to get in, the ability for us to do the job we need to do while we're trying to talk to them and they're not able to hear, or trying to get them on an exam table that's not facilitative to an older person with mobility difficulty. So those are some of the barriers that I see every day in work.
When primary care is discussed and issues related to age-friendly environments and how older adults get to age-friendly environments, it really bothers me because we sometimes overlook basic things, and all of you have touched from your specialties on basic things that we're not considering, and we're still trying to design an age-friendly environment, whatever that means. And I looked at the WHO thing, and it has some good points, but it's still up there. And if you go out of UTMB, and some of you that have traveled to South America or Central America, it's a different thing. It's not up there. It's not an age-friendly environment. It's a completely different thing. And one of the things that really worries me is that when you look at primary care physicians outside academic institutions, they're not aware of the big differences that older populations have. They are not taught in medical school. Most medical schools, I don't know, the US probably has a different thing, but if you go to other countries, most medical schools don't have training specialized on older adults. Occupational therapy is never considered. Physical therapy is a luxury that most populations don't have access to. And so I think it's very useful that we're discussing this, but again, the issue that Dr. Sauter brought a while ago, the issue of education and what we're doing with physicians that graduated 30 years ago and were never exposed to a geriatric ward or to occupational needs of older adults or social work conditions that older adults need in order to be able to lead at least meet their basic needs. And so I guess my question for the panel is how, or do you know, I don't know if you've had time to think about it, because there's a lot of research out there, and we have papers and we have clinical trials and we have things that show that exercise is good for older adults, that the comprehensive geriatric assessment that was put in place 40 years ago and has been shown to save costs and to be better, and patients report that their care is a lot better and we decrease mortality. So there's research, we have data, we know that what we think needs to be done is better for older adults, but still there's a bridge that we haven't been able to build between what we know should be done and what actually primary care physicians are doing for older adults. And is there a way to build that bridge to ensure that the care that we're actually providing for these older adults is the care that they should be getting and not the care that they're getting because that's all they can get?
I think there's some really important observations there. One is that we think and work in our context. We work with what we're familiar with. And the same is true in other countries, in other societies. There's some drivers in our society that are troublesome to me. For example, one of our staff recently made a change. One of her biggest concerns about making that change that involved a relocation was that she was the caregiver for her 86 and 84-year-old couple who were her neighbors, who had 3 children that lived in other states and never came to see them. So our staff member was their primary home caregiver, took them to the grocery, took them to the doctor, helped them get out of the house for exercise or just a social time drive around the community. And so I think, and she was leaving. And her biggest concern was, well, who is going to be the caregiver for my neighbors now? And that's reflective, I think, of a value in or a lack of a value, perhaps, in our society that also influences the way that we look at our elders, and therefore influences caregivers and health professionals' perspectives on the needs of the elderly. And we don't always see that in other societies. We see things that are very different, as a matter of fact, in other societies with regard to, for example, multi-generation households that are really not very common anymore in this country, and yet have been demonstrated as an important way to stabilize and sustain the health of the individuals in that household over time. So I think there are societal factors that are driving a lot of what we deal with as health professionals that go back to some of those root causes that are really very significant barriers, not just structural barriers, but social barriers to the way that we have to adapt our care for the elder in our practice or in our community.
Just to touch on another comment that you made about awareness amongst disciplines everywhere. I think we are a bit privileged at a university like this that has an abundance of resources. If I want to know what somebody does about something, I have a whole list of people I can contact and call. I don't think that's true of a lot of healthcare providers elsewhere. Simple things like being able to access a library with all the evidence I want. No, by the way, if our library doesn't have it, they'll just go and order it from wherever it is I told them it's at, and I can have it at my fingertips. And I think those are real privileges. When I'm talking with students about just awareness, they spend 3 years in a program learning all about physical therapy, about other professions here as well, and sort of how they fit into the scheme of things. But I think one of the newer things that we're talking about a little bit more is spreading the public perception of what you do beyond just you and the immediate people that you know. But a lot of people in my family and my husband's family and my community external to here didn't know what a physical therapist did until I told them. I'm sure you'll find that's true probably for occupational therapy, for social work, and perhaps for PA and NP. I mean, not everyone in the community in general knows what all of the diverse roles are, and certainly not how those roles can play well together. So part of our responsibility, I think, as professionals is to learn what the public perception is, and through either community education, through the education of students, through just how we live our lives as professionals, to be aware of that.
I'd like to also comment that the WHO article on age-friendly was, I was looking for something to anchor this session, something to jump off from, and to get things started. And it seemed to speak to me of some real basic ideas and issues. And Raphael, this is exactly what we're trying to do, is take that basic type of idea and really dig deep into what it really means and where we're going to go from this. And I'm kind of trying to set a placemat, I guess, or setting the table for next month when we really hear from the students. Because a focus group, you're going to hear a slice of the society. And how well that's put together, maybe we'll get enough wide of range of comments and ideas. The thing is, most of the times you get the ones that really have something to say, and those are the ideas you hear. Then there's a lot of ideas that people have that they just don't want to say. They don't want to share it. And so those are the ones that we have to draw from. And I was going to ask a pretty simple question. I promised panel I wouldn't throw any curveballs or anything. But I was wondering, is there a good, and forgive me because I'm not familiar with it, is there a good feedback loop between the patients and the care they get and the health providers? In other words, when they're there, they fill out forms, when they leave, is there something that they could provide back of the kind of care in real general terms? Did they feel they were listened to? Did they feel that they got the information they wanted? Was the care level or whatever? I'm sure there are. Right. So and those are given and they're evaluated and adjusted.
Yeah, the information brought back too. Yeah, there's a survey that goes out to a certain percentage of patients who come into a clinic. They fill them out, and information goes back to the providers so that they see what their scores were and what specific comments were. So.
That's in our setting, though.
Right.
Well, we also have patient care facilitators that actually call patients when they leave the hospital within, I think they have like 5 to 7 days to call those patients, and they ask them how was their care. And they provide names of the individuals that help them, and they can provide comments for us to use to better ourselves. And so we have that, I think Branya on the ACE unit, she does it for us. She makes the phone calls, and we also have this new program called Code Red, Re-Engineering Discharge, and I'm a part of that program where we're looking at how to teach back. So when patients come in and we're talking about chronic illnesses, do you understand? We go over it, then we have them teach back in their language to make sure that not that we're trying to test them, but we're trying to see if we actually explained it correctly. So we have teach back, and then if depending on the disease, we have a program where we try to send nursing, and we do protocols like for congestive heart, where we have a protocol and we send it out in the community where those home health agencies can actually go in and educate more. And then we, of course, have our clinics as well that we utilize for follow-up appointments. And so we try to make sure they have a follow-up appointment. We try to make sure that we're trying to prevent discharges within 30 days, but we also call back within 5 to 7 days. And so we found that has been helpful because patients are being able to voice, if they got the services they received. If they didn't, sometimes it's triage to me. It's triage to maybe the nurse practitioner to make sure these services are in place when they leave. So I can also say on the ACE unit, we're doing a good job of age-friendly healthcare because we do have we do have communication with the clinics, and what I see the most is what I think was most helpful for us is the electronic medical record, because it would take 2 weeks for you to get the information on your patients. Now, when I look at a chart, I'm looking at Andrea's notes, I'm looking for a social work note so I can see what happened so I can continue that care. And so when they leave, I have access to my notes, and sometimes they'll call me and ask me a question. So I would say that yes, we're providing that. And our home health agencies, just recently, we've invited nursing homes to come up, because if we have a problem, we invite them to the hospital and we sit down and talk about what can we do different. We invite home health agencies, so that's what we're in the process of doing on the ACE unit to make sure. And one of the things that I think we talked about it was in the article about what patients really want. They want you to know something about them. They want you to care about them. They want that interaction. They want a doctor that when they come and see them, they don't have to provide all that medical information time and again, because sometimes the patients will say, they should know this already, it's in my chart. And so what I do from a social work standpoint is when I do my assessment, I always find out, what is it that you enjoy doing? Tell me something about yourself. Tell me your hobbies. And most people may not read it, but when that patient comes back in again in the hospital, I can go to them and say, are you still doing this? Are you still doing that? And they say, oh my gosh. And they feel like I remember them, I care about them, I know something about them, and I'm in the door. And then they'll always come to me. The thing about it is, once I give them my card, I'm pretty much married to them because they call me when they leave. And I'm like, oh. So I just do what I have to do. I have to take that time, special time with them, and listen to them. And the social workers, we're more than just social workers. You have to become whatever that patient needs. Sometimes I'm just a listener. I have to listen to them. Sometimes I'm an advocate. If they can't have access to benefits, sometimes there's a discrepancy between the family, and I have become a mediator. I become whatever they need me to be so that I can provide the care for them. And so that's what we do, not only just in the hospital, but we got social workers in the clinic, and we need more social workers in the clinic. We only have 1 for 3 clinics. So we need more so we can provide that care that we need to, because I just have to say one more thing, that the National Association of Social Workers, with this healthcare reform, we've been a proponent. We've been for this for many, many years. So we believe everyone should have access to healthcare, from preventive to acute to chronic to rehabilitation, long-term care, and end of life. And we've always held that view. It's part of our ethical standard. And so I'm reading about all the things, and it's very interesting to me. And I'm really liking some of the things I think we can do better at change, but I don't have all the information, but I think it's going to be good. And I also believe we're going to have, in order to have something good, you have to sacrifice. And in this country, we have to be willing to sacrifice the way we've been doing things. We can't do it the way we've been doing it anymore. So, sorry.
I'm enjoying the passion of the other people on the panel. It's wonderful to be with people who have this passion. I guess I want to turn this question 45 degrees if I could. I became really interested in whether or not the team actually delivers what they think they deliver. And so after home visits, and these are interprofessional team visits of students, I asked them to generate an action list of what they actually did from the minute they walked in to the end. And then I asked them to code what they thought were primary limitations in function and participation, positive, both negative. And then I asked them to describe what they did about that. And I think they were all astounded that they actually did very little about what they knew were the primary problems. So it's really easy to go in with your assessments and check this and check that, and hear these emotive stories and then walk out, and you haven't done very much.
So I think part of our challenge as educators and providers is to develop that reflection cycle on what we actually accomplished. And those action participatory research projects where you act and then you look and then you reflect and then you act again turned out to be very powerful in our settings, made people more mindful of what they were actually doing and not just using words to say what should be done, but what were you doing right now?
Tony, I want to turn your question another 45 degrees. Your question was directed at how do we know that we've done the right things and what is our patient satisfaction? But my other 45-degree direction is related to my own experience of finding a physician for a son in Chicago and finding a physician for a son in Phoenix. And I went online and looked for the specialty and found the ratings of those doctors and found the comments of their peers and their patients about their performance and their service, and found the ratings of the facilities in which they worked. We're in a new era, and it's changing the level of accountability, I think. And so providers need to be aware that that information's out there, and anybody can shop it and find it and learn about them and either believe it and know that it's validated or find that it's not valid and need to try to change that public information. So that accountability is shifted, and it's generally available, it's online, and I would dare say that most clinicians have not looked at what the web says about them in their professional practice. And that, I think that will be changing.
That's very good, because I was thinking, any comments or questions on that? Yes, yeah.
I think it's become even more than it's personal. If you're a healthcare professional, you have to be aware that the information that's out there, that's on Facebook or some of those other things, that it may spill over into your professional life. And I don't know if students that are coming up these days realize that someone might Google them and come up with some information that they put out there for other reasons.
As an educator, when I first had heard about Facebook, I had set up a Facebook account. Not because I ever thought I would use it, but because I wanted to see what the students who were applying for my selective entry courses were saying about themselves and how they were representing themselves. I did not want to send a student to the Capitol in my health policy course who had represented themselves publicly in a way that would not properly reflect on the institution.
Any other? We have about 15 minutes left, and there's two things I'd like to bring up. Eventually I want to kind of move this back, or move it towards the healthcare reform and bring up policy, because I think that's going to be really vital. And the other thing was, in terms of, sometimes if I see my physician, I had a tympanic tear, tympanic memory, and we went through all this thing, and I had a feeling that, he knew that whatever he told me, I would do. I had the background, I got the literature, I was going to take care of this, wasn't going to be a problem. If I have to get on a plane, I'll know what to do or what not to do. I'm sometimes wonder, is there a level of confidence that a health provider can draw from when they see a patient? They just know that that's going to, whatever was done will be okay. They'll be able, or there's levels where, gosh, this is really shaky. I don't know if this is going to work out for this patient in terms of whatever intervention, whatever was suggested. And is there anything you can do about that? Does that go back to the dilemmas of healthcare, with the decision making? And when you aren't quite getting what you want to get.
I think that all comes back, and we all have that regardless of discipline, but that's clinical judgment, and that's looking at someone and saying, and boy, this is just not working, or yeah, this is good, and you move forward, and I think that's ageless. I truly think that's ageless, but I think as you do sort of touchbacks or talkbacks with patients, particularly in a patient where they need that extra second for processing. I think sometimes we're zooming through stuff so fast and we're saying stuff as we're walking out the door, and you walk out and you went, well, I did all the right stuff, but it's not going to work because, and I think that's maybe reflecting more on what you're saying. The patient knows what to do, the patient will get it, but I don't think the patient gets it because it wasn't delivered. That may be the bigger problem.
I think tapping into your safety nets, whether it be your family members, that you can have access to your home health agencies that will be able to be your check and balance. Are they getting it? Do they need a little help in order to have it happen? Is also important.
I think sometimes we distinguish between this professional talk and layperson talk with older adults, but there's quite a lot of in between. I've talked to some really, really intelligent patients who sometimes wanted more information than what they were getting from healthcare providers. So, as a goal for any sort of intervention or assessment or anything I'm doing, I try to figure out from them, what kind of an outcome or an expectation can I share that is straightforward, but that person can understand and be responsible for helping to keep track of. More empowerment, and part of that comes from, like Lisa said, being in a hospital setting where you have a couple of visits sometimes to spend with a person. And you may or may not be that same, this happens a lot in therapy, there are different transitions in care where you're going to have this one person in the hospital, then you're going to have this person in home health, and then you're going to have this person outpatient, and that's if you're lucky to get all of those settings of service. So, and really empowering that person early on when you meet them to, here are the overarching goals. Here's how the PT part fits into the rest of your medical care. Tell me what, like you said, tell me what you understand about what we've talked about, and what can you track and measure. There's just this secret chart over here, and you can't know what I'm writing down. But when we do the patient goals, sometimes students will say, well, what? Which one was that? I was like, you can't proceed without knowing the goals. It really has to be tied into, there's not, here's the patient goals, and then here's the goals that we're going to have that are separate over here. It has to be linked. And in terms of patient feedback, there needs to be an understanding, if it's with the patient, if it's with the family, ideally collectively, everyone involved in their care, to understand what that overarching goal is. And there are variations in the buy-in to that, surely, but the little bit of extra time I find does often help to overcome that.
I think we commonly say in the hospitals that some of our patients, they have the white coat syndrome. When all the team come in, you got this group, faculty, students, and residents come in, they forget everything they want to ask, and so the team is telling them this, and the minute they leave, I might combine it, I need to know this, I need to ask this question. So what we try to do is we go in the room with them, we say, okay, write down all your questions right now. Sometimes I'll help them write them down. Tell me everything you want to write. Hold on to this. I give them paper and pen. So when the teams come back, you can ask these specific questions. Now, they might be saying these other things, but make sure these questions are answered. And they tend to do better, and I find out that the teams like it better because they'll go in, do you have any other questions? And the family's like this. And it's like they don't know what they don't know. So, and I'm finding out that works. We actually have booklets now that we're going to start passing out to the patients where they give them the opportunity to write down their questions about what their needs are. So I think that helps as far as making sure they're aware of what's going on. No, and we also have a communication board in the room that we're now using. The nurses are writing the goal. The goal today is to get up with PT. The goal is today is to you're gonna go down for a particular test, so that they're always aware of what's going on, and they can be a part of participating in their health care.
Okay, so healthcare reform is going to make some changes, maybe here or there. I'm not really sure yet at all how much that will affect, for example, an institution like UTMB. Where will we find some effects that may impact how care for older adults is actually given and provided? And if it's at the policy level, will it actually make an improvement? Possibly. There's no way of really knowing, I think. But thoughts on that?
Yes. Yes. Definitely thoughts. Until I was working in an environment where public policy decisions were being made, I naively assumed that those policies were made with good judgment based on good information. And over the years, I've learned that public policy is really driven by passion and ideology more than it is facts. And I think that obligates every citizen to share what they know with those who are responsible for establishing and sustaining policy. That's my soapbox. In the current situation where we're all affected by the debate, some of which is rhetorical, on health reform, which is the health policy issue now. I think we have to share what we know, and share what we believe, because that touches on the passions, and we have to share stories about what really makes a difference, and puts a face on a policy that affects the lives of not one or two, but thousands and thousands and thousands of people. And I think that's true for our work in Austin and those that represent us, and I think it's true for the work of those in Washington that represent us. I would also share an observation that our federal government, at least in the Congress, is run by 27 to 34-year-olds. And in the legislature, they're younger than that. It's the staffers who are very bright people, but they're only as good as the information that they're provided. And I think that's where it really makes a difference. And each and every person in the community has a role to play in informing those who are providing the information that either meets an agenda or counters an agenda and influences a vote. So I think we're in a very critical time. In the first session, I think it was mentioned that we're approaching 1 out of every $5 spent in the U.S. being spent in healthcare. Actually, it's being spent in illness care. That's not sustainable. And so I think we have to, our purpose is to think about care of the older folks that are around us. But even then, I think we have to shift our thinking from illness care to wellness and prevention, and look at those things that can reduce disability and enhance lifestyle, not just in the elders, but across the age range. And I think that's absolutely critically important right now in our history.
Questions, comments on that?
I wholeheartedly agree. I just also want to put in a plug for mental health. I think the new healthcare reform has some promising initiatives for mental health, and I think it's a national disgrace that we don't reach out to people or serve people with mental health. And we really haven't been talking about that today. We've really been talking about physical health issues. So it's a neglected area.
I remember when MHMR more or less went away on the island down here. It was unreal, and we see, I think, down the road some of the impact and the actual consequences of something like that.
I turn to the remote audience and see.
Yes. Yeah. We're looking for some questions and comments. You can call in. I could put the number back on. And so any questions from Baylor up there in the top left? Any comments? Okay. What, let's see, we have, I think, Lamar in the top right. Okay. All good? Yeah, they're waving. Yeah. That's great. Okay, and Victoria College. All right. Yeah, because I was thinking also of what I think Rebecca was saying about the goal. You know, when you see the patient, what's the goal? And it's like, as opposed, like, say someone says, you know, I want to just be able to get down my stairs safely. I'm having a hard time, you know, and things that trigger, you know, where you go in terms of the direction and the questions then you ask for the follow-ups and things. As opposed to someone that used to run 5Ks on a regular basis and maybe is having a hard time getting that 1K down, you know, and so is that more cardiac, things like that. So, I mean, those things get covered, you know, because, the the experts are there. And so, you know, when it comes to, you know, if we had to just forget the policy part, we might be on a good road towards better health care for older adults. I'd like to think that. We have 3 minutes for some closing comments.
I think probably one of the best things that's happened in the last couple of years, and it was alluded to, but I think really to stress this, is the focus on interprofessional education. I'm very involved in medical education at the national level as well, and there's a huge push and focus on interprofessional education to try to help students of all disciplines play in the sandbox together. And understand that together we are much stronger than individually, and that there's kind of a change, a shift in the way people have looked at that. I know when I came into medicine many years ago, you were, you did your thing, and then if you needed help, you reached out. And now the attitude, I think, is very different, and the educational focus is different. And certainly some of the efforts here at UTMB with Synergy have been grassroots and starting, and there's some beautiful work that's being done across the country, and I really encourage all of you that are interested in that to stay involved, because it's ultimately going to make a huge difference for our patients.
I think that's one thing that I like that Lisa said about they don't know what they don't know. And that's so true, not only for our older adults, but also for our youth. It's hard to teach someone something they're not familiar with. If you start when they're young and provide them a good foundation learning, what does a nurse do? What does a physical therapist do? And they will share amongst themselves, and they'll grow up, and that will become the foundation for the next generation. So we need to learn from our past errors or in our own ignorance, because we didn't know that we didn't know, so we can know and we can share that information. So start, just like what Steve says, as prevention. Well, how do you start prevention? You start when they're young, not when they're middle-aged or they're older adults. You start when they're young.
Okay. On that note, we end geriatrics on a young note. Perfect. Any last comments? Or yeah, Susan.
I think it was Dr. Zotter who started with a quote about experience. Education is one thing, and then experience is not
Can't teach
teachable.
experience.
Can you just repeat that quote one more time?
Yeah, I mean,
It's my concept of helping people learn is you can't teach experience, and you can't. You have to have it, but we have to provide opportunities for people to have those experiences. And I think the reflective learning that Gretchen referred to is so critical in making those experiences meaningful and teaching people how to always use those to grow.
All right, well, I think that we're going to wrap this up, and I'd like to thank our panel tremendously. Thank you. And for the sites, the remote sites, they're packing up, getting their paperwork done. We have evaluation forms to fill out about this session that'll help us in future sessions. And so I appreciate you being here and staying for the 3 hours. And we'll see you next month, May 18th.